Hey guys, we're very excited. This is Dr. Ranjan Mahajan, board certified internist. We're back again doing our webcast, and I'm very excited. I got a good friend of mine and very learned man, Dr. Lalit Kalra. He's a prominent infectious disease specialist in our area, and he was kind enough to spend some time despite his busy schedule with our webcast. And we're going to cover a lot of areas, on COVID-19, since now we are, since last January till May now, we got a year and a half almost of experience with COVID-19, and Dr. Kalra will cover the breadth of topics. What is COVID-19? What worked? What didn't work? How was his clinical experience of managing patient with COVID-19 over the last year and a half? What changed? What stayed the same? What's the role of the vaccinations? And we just got the FDA emergency use authorization for Pfizer vaccine for age 12 to 18. So he's going to touch on that as well. And any other pearls of wisdom he gained for all those years of, year and a half of managing the novel coronavirus, COVID-19. So let me give you a brief rundown on his credentials. Dr. Kalra has, phenomenal credentials. He went to UPenn for his infectious disease fellowship, and then he works locally with the infectious disease group, and he goes to Mount Hospital. That's his main hospital, but he goes to other Baycare facilities as well. And he's on the board for infectious control at Baker Alliance. So he has wealth of knowledge. So let's get him on our panel and get started. But for those of you who don't know me, my name is Dr. Ranjan Mahajan. I'm a board certified internist, and we do once a month webcast on different topics of interest for our local community. And we have an office right here in beautiful Tampa Bay in Largo, and we'll give you a brief introduction to our practice. At Mahajan Medical Center, we care to listen to our patients. Proudly serving the needs of Tampa Bay in primary care for 25 years and counting. Hi, thank you for listening to that video. Let's get Dr. Kalra on board. Hey Lalit, how are you?
Hey, Dr. Mahajan, thank you for having me. Really appreciate it that you acknowledged me well. Just a correction. Rather than UPenn, I was in Penn State.
Okay.
So that was a little bit correction. But yeah, thank you. And I've been actually been doing infectious disease for quite some time now. As you know that I'm from India, and infectious disease start as we joined the medical school there, starting from malaria, typhoid. So, and there is no specialty in infectious disease in India. When I came here, so it was a natural inclination towards infectious diseases, and here we are after a year of pandemic, and I think I love what I do. Yeah.
That's great, Lalit, and we are very happy to have expert like you in our midst during a pandemic like we went through. And unfortunately, it's not over yet. We're still seeing countries like India and Brazil having dire straits, and healthcare is suffering and straining with the number of cases. So let's get your thoughts on what brought you into infectious disease. I know you got early exposure, and then you did your MD medicine as well, so you had host of experience or different specialties. So what got you into infectious disease?
So infectious disease, is something which I was interested in since I started the medical school, and um, as uh, as the time went by, it was more close to me during my MD medicine, particularly in India. When I came here, I think the infectious disease was under recognized, and a lot of people, we as a people in the third world countries still think that there are no infectious disease in the United States. But when I came here, there was actually a underserved area of infectious disease, and I thought this will be a good choice for me because I know it very well, and I have a lot of experience from simple skin infections to bacteremias to endocarditis to osteomyelitis. I've seen it all, and obviously the COVID was the time when the infectious disease came in more importance. People start recognizing infectious disease specialists since last 1.5 year. So I think infectious disease is an important specialty which was under recognized, and I think it's getting its attention now with the pandemic.
No, the infectious disease is going to be always critical with the evolving multi-drug resistant bugs, and COVID just brought it to the limelight how fragile our overall biosphere is with human encroachment, as you're going to show us in a little bit about the life cycle of how COVID happened. It's all boils down to we as humans are not as mindful of other organisms and other animals on the earth, and it's coming back to haunt us. And the bugs are jumping from one wild species to us, and it's very critical that we as humans take responsibility and think of well-being of the whole biosphere, not just ourselves. So let's get started on the COVID journey with you, Lalit. So here's our first slide. It's a beautiful, very pretty virus, but very deceptive. Um, you know,
Yeah, COVID, the virus is actually SARS-CoV-2. It came from the severe adult respiratory syndrome back in 2002, when it was the first time this was diagnosed, and this was found to be epidemic in the China side, I think. And since then, there are multiple mutations has happened from the SARS-CoV to MERS, and then now COVID-19. COVID-19 actually is a term. If you break it down, CO is for coronavirus, VI is the virus, and D is the disease. So coronavirus disease, and because it was identified in 2019, it is called COVID-19. It is simplified version of what we have to say in the technical words. So that's as simple as it. Coronavirus disease in 2019 is called COVID-19. Now, you see, this virus is a very beautiful virus. It has a crown-like spikes, and that's why it's called coronavirus. And you will be surprised that we have coronaviruses around since 1960s. We never bothered about them because the disease they caused was very mild, just like a common cold. And there are like 4 viruses which are prevalent in the community, um, which are the common human coronaviruses, which are listed on the slide. I don't want to go into the numbers; it will be more complicating the talk. Now, these are human coronaviruses. When the animal coronaviruses jump to the humans, they cause problem. You know, so if I can go back to last slide, please. So, MERS-CoV, SARS-CoV, and SARS-CoV-2. These are all viruses which jump from bat to the humans through an intermediate host. As you see in this slide, in 2002, civet was the intermediate host, and it jumped into the humans. And we saw at that time, it was very deadly. It had like 40% mortality. We didn't have cure for that. but because it was limited to one part of the world, we didn't, talk about it much later on. Same thing happened in 2012 when in Middle East, the same virus coronavirus jumped from bat to camel and camel to human. And at that time we saw again Middle East respiratory syndrome. That was the name of the disease. And because it was again limited to one area, we didn't talk about it much at that time. Now 7 years later, this COVID, which is in 2019, coronavirus jumped from the bat to the pangolin, and pangolin to the humans. Pangolin is a animal. Actually, I have a picture of that on the slide if you have that. So pangolin is an animal. Go to the next one, Ranjan. So pangolin is an animal which is actually has some importance of these scales used in some treatment forms in the China area. And you see, it's a beautiful animal, and people pet them. So one theory is that it is came through this pangolin, and the other theory is it came through the wet market, when the meat was sold. Obviously, there are other theories which obviously are very not a right nice thing to talk at this time. But there are multiple theories that it may be a leak from the viral lab or something. But there is no proof at this time. So we still think it is a natural jump from bat to pangolin and pangolin to humans. So this virus is a single-stranded RNA virus. RNA virus in general, they have a tendency to mutate, and they keep on mutating as the time goes, as they jump from host to host, as they replicate. Now, it is important to understand what is this coronavirus structure is like, because that is the essential part of our finding a treatment, finding a vaccination, and how to prevent it from happening further, spreading it further. So as you see, it's a RNA virus. As you see in the center, there is a single-stranded RNA which has a nucleocapsids in between. It is covered by a lipid membrane, and there is a receptor protein called envelope protein and spike protein. We probably know spike protein very well because we have anti-spike protein vaccination with mRNA with Pfizer and Moderna in United States. What is important to know is this structure of spike protein is very essential for this virus to go into the host cell, which we will talk in the later slides. So if we are able to stop the viral entry into the human host cell, then we should be able to prevent it from causing the disease, as well as prevent it from replicating and spread of the disease as well. So if you go next slide. Nonetheless, this spike protein has three components. One is called receptor binding domain, RBD, and S1 and S2. When the coronavirus is inhaled, it goes to the lungs, and we have the human cell identified here as this square box. It has a receptor called ACE2 receptor. And these ACE2 receptors are the receptor for this spike protein. When the spike protein attached to the ACE2 receptor, it is internalized into the cell as a whole virus by the process of endocytosis. It opens up, and then this mRNA, this RNA is released into the human cell. And this, as you know, all the viruses use human machinery to replicate. This RNA replicate by the help of the polymerases and replicases into the multiple RNAs, and with the different part of the RNA has gene code gene for the different part of the viral body, including the spike protein, envelope protein, membrane, then
I know we're getting very technical. Let's just, focus on, the things you covered so far where the therapeutics has been directed, Lalit. So I know, for example, the SARS coronavirus, the spike protein has been of interest and very successfully used by the vaccination, the mRNA vaccine, the Moderna and the Pfizer, as well as J&J and the AstraZeneca, though different ways to attack the spike protein, but they all attack spike protein and has very effective 90% plus vaccine in mRNA, and the J&J and AstraZeneca has been very effective, at least in reducing mortality, and severe. So, do you want to comment on that piece? How that came about?
Yeah, so it's interesting that the biotechnology has so much so progressed that we are able to inject mRNA, and that actually uh, makes a protein called, which is identical to the spike protein, exposing our immune system to the spike protein without virus entering our body. Our immune system makes the antibodies to the spike protein, and when you get the second shot, it already your B cells and memory cells have a memory of your previous episode of exposure to the spike protein. So they process the antigen very quickly and start making the antibodies. If you go to the life cycle, I will actually show you which part is important. Now, spike protein is essential for the virus to enter the host cell. These antibodies actually attack to the not attack actually it bind with the spike protein, so that the receptor antigen and antibody complex prevent it from entering the human cell. Now, if we are preventing the virus of viral entry to the human cell, we are preventing its replication, we are preventing its increase in the viral load in the human body, and decreasing the disease process. At the same time, when we
So
are
let
not
me
replicating.
stop you right here. So you introduced this concept of the monoclonal antibodies now. So let's just give the audience, that it is available. There are two companies which make it, and it is available in our community. And but you have to do in the first few days of the disease, and it is only given by infusion. So that's the limiting part of the application of this uh, good treatment. But you have to do in first few days, and you have to go to an infusion center. For example, you want to talk, Lalit, what's the local infusion center if patients get COVID-19, where they should call and get this infusion?
Right. So there are two kind of, as you said, monoclonal antibodies. Monoclonal antibodies actually are important in first 10 days of your disease process. From the day of your symptoms, uh, symptoms should be mild to moderate, and it is approved as an emergency authorization by FDA for first 10 days of the disease only. It is important that if you are 65 and above, or if you are 54 and above with comorbid conditions such as diabetes, obesity, hypertension, and if you have symptoms of coronavirus, fever, uh, body ache, you still don't have shortness of breath, and if you're tested positive for COVID with the help of your primary provider, and if you are you falls in that category of 65 and above or 54 and above with the comorbid condition, you are actually eligible for getting a monoclonal antibody before it is too late. When I say before it is too late, once you start developing shortness of breath and you are hypoxic, it is not indicated and it does not work at that time.
And also, let me bring another point about vaccination and monoclonal antibody infusion, Lalit, if you may, that if you get this treatment or you got this treatment in the past, and then you have to wait 90 days before you get the vaccine, because otherwise the vaccine won't be as robust in creating the antibody response, correct?
Yeah, so if suppose you had a COVID infection and you got the monoclonal antibody, or you got the convalescent plasma, which is again a polyclonal antibody infusion, but it's from the patient who recovered from the COVID. You are not eligible to get vaccination for first 90 days after you got the monoclonal antibody or the convalescent plasma. The reason being, you already have the antibodies in your system, and the immune response will not be as great for the vaccination because you already have the antibodies. So it is not indicated in first 90 days of the infusion of either monoclonal antibody or plasma.
We get a lot of these questions. I'm pretty sure you get it too, Lalit, that I just got COVID. I finished with my infection. When should I get the vaccine? What I read, and correct me if I'm wrong, the CDC recommend once you finish with your quarantine and you're not transmissible at that point, you can go ahead and get the vaccine safely. So a lot of patient. Also, why don't you address that issue? Is that the correct assumption?
So if you got the COVID and you did not have much symptoms, you did not require the monoclonal antibody, you did not require the hospitalization with convalescent plasma, then you should be able to get the vaccination immediately as you finish the quarantine period. Um, and you should not means you can delay it, but it is recommended to get it as soon as possible. Uh, uh, there's no point in waiting with that. So
And the other
COVID
related
infection
question. Go ahead. I'm sorry. Go ahead.
COVID infection itself is not a contraindication to get the vaccination.
Right. So, and a lot of patients ask me, I'm going to have antibodies since I got infected. What's the rationale? And my understanding, and correct me if I'm wrong, is that you have to hit a jackpot with COVID-19 to get the neutralizing antibodies. You will get antibodies. The IgG, IgM will go up, but that does not mean those are the blocking or the neutralizing antibodies. With vaccination, they are designed against spike protein. They're designed to give you longer lasting neutralizing antibodies. Is my assumption correct, Lalit?
Yes, you are correct. Basically, if you got COVID, depending on your severity of infection, suppose you got a asymptomatic infection or suppose you were in ICU, there will be a different level of antibody response in your body. Asymptomatic infection will not produce that much antibody in your system. In a patient who has a severe infection will have more antibody titers. So will there be neutralizing titers in a patient who had asymptomatic infection? It's a questionable, and we do not know the answer to that. So because of its so much variable response in different people, we want a kind of consistent response with a standard dose of vaccination so that all humans are at the same level and to get the herd immunity at the same level to prevent its progression or its transmission from in the community.
That's a great point, Lalit. And while we are on the treatment modalities, let me pick your brain. What other treatment modalities, in your experience now treating COVID patients for a year and a half, has been effective? I know remdesivir has been around for some time, and it does reduce the number of hospital days, but it's not a cure. And then the British study, Recover, showed the value of the steroids, but that too you have to use at the right time, otherwise, it could be damaging. So, what anything else other than the monoclonal antibodies you mentioned already, and convalescent plasma has not been panned out what it thought to be, and in fact, some studies have shown it could be more injurious because you're adding the fluid load when the patient is sicker on the vents. Anything else you want to add with your journey and being the expert?
Right. So COVID, if you are within first few days in the sense first 10 to 14 days, you have a different. The phase of the disease you are in is the virus is still replicating. So in those stages when the virus is still replicating, then you can use the remdesivir, which is a antiviral medication which prevents the virus from replication, and so that is only useful in first 10 to 14 days when you have not you are not going through a antigen antibody complex reaction. Basically, what that is, the indication is that if you have hypoxia, oxygen saturation 94 or below, then you should be in the hospital and start remdesivir as soon as possible. Early it is given, the better it is. And you are right, there is no mortality benefit. It definitely reduces the hospital stay time. Also, if you pass that stage of 14 days, some authorities still recommend using remdesivir, but it is questionable how much it will benefit. Once you are at the stage when you are using oxygen, 94% and below is your pulse ox, and you are requiring oxygen, steroid are important part of the treatment. Uh, why your oxygen requirement is going up is due to the lung inflammation because of the antigen antibody reaction, and we are trying to decrease the inflammation of your lung as well as your immunity. It's a kind of controversial to say that you are decreasing your immunity, because there is a uh, thought that we should increase the immunity to fight the COVID. But nonetheless, when you are at the stage, we are trying to decrease your immune system to fight the virus, and also decreasing the inflammation with the use of steroids. And steroids are important part of the treatment when you are in the hypoxic stage, and it has definitely it definitely has been a life-saving medication. Now, when you are not responding to steroids, you are done with the remdesivir, and your oxygen saturation suddenly drops, then we call it as a cytokine storm, when your saturation suddenly dropped from 94 to 85 in 24 hours, and you were actually requiring 2 liters oxygen, and now requiring 15 liters of oxygen. There is some thought about checking the interleukin 6 levels at that time, but that has not been correlated with the clinical picture. So at that time, we use tocilizumab, which is an anti-interleukin 6 antibody, to bind the IL-6 to prevent the lung damage to happen. So far, I think the oxygen
Isn't
therapy.
it getting a little bit controversial because there's higher secondary infection with the use of the IL-6 inhibitors? I know we were gung ho when we started out with the IL-6 inhibitor, and a little bit dampening of the thought with more secondary infections in sicker patients with the use of the IL-6. What's your thoughts on that?
Yeah, I mean, I have seen cases of aspergillosis in a patient who has received IL-6 inhibitor. But on the back thought, we would think that that particular patient was actually on ventilator for 2 months, believe it or not, and she made it. And we believe there may be some role of preventing cytokine storm from progressing with the use of Actemra, or not. We should not use the brand name, but interleukin 6 inhibitor tocilizumab. So you are right that there is an increased risk of fungal infections, and also in some cases you may start seeing reactivation of tuberculosis, or a atypical mycobacterial infection. Recently, if you might be reviewing the literature, there is an increase in the incidence of the mucormycosis in India recently, but that has more linked to the use of steroids also. So
And,
if we
and,
use
you
a steroid.
I'm glad you mentioned mucormycosis. I'm getting a lot of my friends in India talking about it, and ENT, are getting a whole lot of cases, and unfortunately, it's a serious ramification. You end up losing your eyesight, and they have to, eviscerate the eye. So that's a serious. But there is some thought that we're not seeing as much in the West as we're seeing in the India. Maybe the caseload is more, maybe as you said, steroids and Actemra or anti-IL-6 inhibitors are used more aggressively there. But there's also thought that there could be linked to the way the oxygen gets supplied to the tubing there. There is some lack of distilled water, or they're using the regular water. So there is other issues in terms of, but yes, with any of the steroids, any of the diabetics, any of the patient who already immunocompromised, the transplant patients, the antifungal or the fungal diseases as secondary infection become a serious concern. While we're talking of India, before we get off the topic on the treatment modalities, is there anything else you want to bring to the table on the treatment modalities on the horizon, or new, exciting, which could be of use? I know till the studies are done, and we don't know, but at least looking on paper, sometimes things look good.
Yeah, there are definitely studies going on with the use of antiviral agents in the form of inhalation and oral forms, which can be, which is actually going to revolutionize the treatment as an outpatient treatment before the patient end up in the hospital. But nothing is in concrete yet. It is still, the studies are going on. No data is available, which is actually useful right now to share. There is definitely a push for ivermectin in the Eastern world, but we have used it here. There's not much we found usefulness of the ivermectin. Uh, then there is a antiviral medication from Japan, which is being used in Eastern world as well for 14 days. But I don't think there are good studies to support the data yet. So at this time, I will not, say anything about the medication which are not working, because then, how the hydroxychloroquine got the pump. So let's stay with the data we have right now.
Right. So, in summary, I think the best thing is to avoid it because the treatments are mostly supportive, and the steroid has been a game changer. Other than that, it's vaccination, and not to get it is your best bet.
Yeah, I will definitely do anything to not get COVID, because once you
Yes.
get COVID, we don't know the long-term problems which you will be seeing with the COVID. As you see, long haulers, we are calling them long haulers, brain fog, generalized weakness, chronic fatigue syndrome. So you will be seeing those problem. You will see more than me, because I'm a hospital inpatient doctor. You will be,
We
dealing with those.
already seeing it. We already seeing it. Patients who got in March, April, Lalit, they are coming to us with those unfortunate, and they're still, it is presenting a picture like interstitial fibrosis in certain patients, and that's a serious situation where they will never recover.
Yeah, I'm
Uh,
glad you brought it up. This interstitial fibrosis is going to be a big problem in next few years. You will see, and I will see. The more inflammation of the lung is, if it is not suppressed in the right time, it heals with the scarring. And scarring of the lung is basically lung fibrosis, and so you will definitely see that problem in the future. People who
we
are
should
right now.
also, I think, debunk, while we're debunking thing, which we know for sure doesn't work and maybe more dangerous, is the use of antibiotics early on. Like, we've seen it in Eastern world, and countries where they're using azithromycin and doxycycline. I think it's just a harm because those medications are changing your microbiome of your upper respiratory and lower respiratory and your GI tract, which you need healthy microbiome to fight infections. And B, azithromycin can affect your QT intervals and cause serious cardiac arrhythmia in older folks. So, and then if they're taking other medications, it will interact with those medications. So I think it's absolutely very important not to use antibiotics without having a real concern for secondary infection. What's your thoughts on that?
So far in 1.5 year, I never required to use antibiotic on a COVID patient, unless they developed a line infection, they developed another secondary bacterial infection, but never in the first few days when you have a typical picture of viral pneumonia. I will avoid using any antibiotic in those, and I'm actually against using antibiotics in general if we don't need to. Obviously, antibiotics
Absolutely.
are life-saving medications. But you are right. I've seen prescriptions of doxy and azithromycin and ivermectin. They are all lump sum together, and people are sometimes get more worse with that. And you are right that development of the ventricular arrhythmias. If you already have a prolonged QT, suppose you are also taking a diflucan with it. Suppose you are taking a amiodarone with it, and it is not being interaction checks is not very common practice in general, either east or west. And unless somebody carefully prescribes it, it can be a detrimental thing. You're right.
Now let's move to India. I know they're close to our hearts. We both were trained there, and our families are still there, and and our families are suffering. In India, our friends are dying. I just got a message. We had a med school resident who just got out of MBBS in our med school in the University of Delhi, and 24-year-old guy, died from got a COVID and got thromboembolic event to the brain and died. So a lot of sad situation there. Let's just talk about in general, not bring sadness. Let's talk about variants now, Lalit, if you may. I know that's been the hot topic. How the mutations are creating a havoc with the second wave, so-called in countries like India, which in the first wave didn't have as much impact, and there was theories going around their younger population, and they have SARS go through there before, or other coronaviruses go through, other dengue virus and whatnot, and they are immune to getting COVID-19, and unfortunately that theory didn't pan out, and they got a very nasty and very huge tsunami of cases in India. What's your take on that before you get to the variant? What was the causes? What you've seen so far in your thinking? I know the dust is not settled yet, so it's still ongoing, the thought process. But what's your take?
So I do think that mutations have a role to play in the second wave of any country, whether it's UK, whether it's Brazil, whether it's South Africa, or now India. Um, as I said, RNA viruses are they are constantly changing. Their uh, their genes are constantly mutating as they replicate. Errors happen. With the errors, there can be a mutation where the virus terminates itself, or it can become more infectious. And there are certain mutations has been identified, and whenever there is a second wave, whether it was UK or India, there are mutations identified which has increased the infectiousness, and as well as it also do a immune escape. Immune escape basically means that they do certain mutation when the antibodies which were from the previous infection or convalescent plasma or monoclonal antibody, they change the target. So now they don't work as much they should be working. And now of possibility is the vaccination also may need to be changed, or we have to get another dose based on the virus replication and mutations. Now I do believe that humans are social, and they tend to go out of the houses as soon as they are allowed to. And I think same thing happened in these countries. Once the guards were off, there was a socialization more than ever, because they were not in contact with anybody for a year, and then all of a sudden you got the freedom to go out. Obviously there are some mass gatherings, religious gatherings, political rallies, and it's not just one country. Everywhere I think we have seen the same thing. So I think it's a mixture of both increased infectiousness of the virus, where the virus used to infect from 1% to 5%. Now it was infecting 20% at a time with one sneeze only. And even person in the same hallway, if you sneeze on one side, it will be affecting the other side. So I think it's a mixture of all of them together, which has caused this massive second wave, or we can call tsunami of the waves.
That's a great insight, Lalit. Let me bring some fan following of you. There's Julie saying, um, so nice to see Dr. Kalra. He's a great doctor. I agree, Julie, with you. That's why we have him on the show.
Thank you, Julie.
And we got Maria, another nurse from On Plan, saying, hi, Dr. Mahajan. Hi, Dr. Kalra. Uh,
Hi, Maria.
and then we got your boss of the house saying hello. Yeah, she's listening to you, so be careful, don't badmouth her. And then Mark, a regular listener, saying he got the vaccine. He was having a hard time finding a place, so I sent him to Largo Med. They are giving the walk-in Pfizer vaccine, so that's a good program they're doing, and I'm glad you got it, Mark. So let's talk about vaccine. You know, the hopeful news. I know the India and Brazil is sad news, but let's talk about hopeful news. And I looked at the data on one country, which I'm very excited to talk to you about, is Israel. So, as you know, Lalit, in Israel, they vaccinated most of the population 18 and above. And they got about 60% vaccination in thereabouts in the country of 9 million. And a couple of days ago, I looked at their data, and out of 9 million, they had only 61 cases of COVID. And they got the Pfizer vaccine. They were smart, they booked ahead, and they were lucky to get it also with the supply delays and all that. So that's a very interesting piece that if you can bring it down to that level by using a vaccine which is already available, that's a hope for the whole world that if we can get the vaccines ramped up in the scale and get some vaccine equity throughout the world, because we may get access here, we do have access here, but it's a shame that United States we have 35% adults vaccinated so far, and now we're seeing a wall where people are not interested. And I think people need to take note of what happened to countries like India and Brazil. It will come back here too if we don't use this golden opportunity when the caseload is going down in the United States and we are not as stretched in our facilities to go ahead and get vaccinated. Otherwise we're going to go through the second and third and fourth waves. What's your take on that?
No, I agree with you. I think the vaccination is the only cure, or you can say cure or prevention. I think prevention is the best thing. So vaccination is the only thing which will prevent you. We know that there's going to be a bumpy road ahead. Mutations will come. We might have to do another vaccination, second shot or third shot. But if you try to prevent virus entering into the host cell, and it prevents from the replication of the virus, that's the only way the mutations will not happen. So if you have a vaccine, if you have people who got vaccination done, they will get the virus in their nasopharynx for sure, but that virus will not enter the human host cell for the replication. And think of it, if you have a virus going into your host cell and they're replicating, so one virus is going into becoming 100 viruses at the same time, and you are more infectious then, and you are spreading it more, and obviously you become sick with that too. So if you get the virus vaccination, the virus will not enter the host cell, it will not replicate, your viral load will be low, you will be less transmitting, and at the same time you will not get sick as you as other people will. So I think it's a win-win situation to do the vaccination. A mass vaccination should be done. Education, I always educate. I got my vaccination early in time, and I didn't feel any side effects, which I'm sure that some people get the side effect and they worry about it and they don't go for the vaccination. But definitely, this is the only answer we have. I take it as a, as you brought it up, that obviously we can get the second wave or third wave. Take it as a game of chess, and you are playing against the virus, so you have to think ahead of time what is the next step of the virus. Next step of the virus, we know it's going to mutate, and to prevent the mutation we have to prevent the replication, and to prevent the replication, vaccination is the only answer.
While we're on vaccination, Lalit, I know we got the emergency use authorization for the age group 12 to 18 for Pfizer. And I know you got teenager kids and I got teenager kids. So what's your take on that? I know the Pfizer study was skimpy, about 1,300 people only, but with between 16 and 18, millions of teenagers already got it and have good safety profile and efficacy profile in that. You feel, though the disease is not as serious in the children that we've seen so far, should we advise to the 12 to 18 and once it gets even younger kids to take the vaccine?
I will definitely get my son vaccinated. He's 15. Think of them, going to the school back in after the summer and the fall, and if they are vaccinated, then it will be easy transition. Um, it's hard for the kids to be, masked all the time. They hang out with their friends, and so I think 12 to 16 is a good age where there is a transition between the kids and the adult. I will apply the data to the adult, to the kids, the teenager also, because we have vaccinated many, many million people right now, and we have not seen much side effects, at least from the vaccination what we are seeing here in the United States. Obviously, it is too early for the late side effects. We will not be able to know after few, unless it is the few years are gone. But I think it's the catch 22. Either you get a COVID and spread it in the community, or you prevent it from getting it and take some, pain in your arm after the shot. I think I will go for the vaccination for the teenagers.
That's a good advice, Lalit. So, now there's J&J vaccine out there, and, they put in pause earlier with the, but 7 young ladies who got, some thrombo coagulation disorder with J&J vaccine, and then the FDA put the pause off, and yeah, it's easily available and it's one shot. So, I'm telling all my patients to go for that if that's the only option available, because it's still very effective in preventing the mortality, that means the death, and serious disease, as effective as mRNA vaccines. What's your take on the J&J vaccine?
So, thromboembolic events, they are common in general without any disease also. COVID itself actually affects the vascular system, as you know, and it increases the thrombosis, results in the pulmonary embolisms, results in the stroke, results in the coronary artery disease, acute coronary syndromes. So COVID itself increases the risk of thromboembolism, and that is much more higher than the vaccination itself. So I think, if you have to pick between the disease and the vaccination, statistically it is still not that much to prevent one case of coronavirus with the J&J vaccine. It is statistically not higher. I understand there were nine cases, but if you don't have other option, I know that we have better options, but if you have an option of vaccination with J&J, I will definitely recommend it. You should get the vaccination with whatever you are getting right now. I think as the time pass by and you are exposed to COVID, that will be the boat is missed at that time.
Right, and as now, with the older population vaccinated in the United States, we're seeing more cases in 50 and less now. So, and that's has been where the most vaccine hesitancy has been, in the 50 and less. So, the virus does not care. It will just find a new host, a new age group, and it will keep going down. Whoever does not have the immunity will catch it, and unfortunately, it's unpredictable. I've seen, though we've seen more morbidity and mortality in patients with comorbid conditions, and age, like diabetes, obesity, COPD, CHF, hypertension. But we're seeing unpredictably in healthy people too, that they get serious disease and they die. So, just because you exercise is good, but it does not prevent you from not getting COVID. So the vaccination should be taken by each and everyone, and take, as you said, any vaccine available, because the key is to prevent death, and key is to prevent hospitalization, and all these vaccines work wonderfully for that goal. Uh, Correct?
Absolutely, absolutely. I will definitely recommend vaccination. In fact, all my close family members are all vaccinated, and I push for every patient I come in contact with, every friend I come in contact with, to get vaccinated as soon as they can. Doesn't matter what vaccine they are getting. Right now, the key is to get vaccinated and prevent the spread, prevent the disease. And you rightly pointed it out. The disease is very unpredictable. You come to the hospital walking and talking, and within 3 days you are intubated with a ventilator. And we feel so helpless in those situations. We can't do much, and other than supportive care and steroids. But some people, succumb quickly, and we don't want you to be one of them. If you get asymptomatic infection, great, you are lucky. But it can go either way anytime. So you should get vaccinated for sure.
Right. Let's talk about the variants a little bit. I know that's been in news quite a bit, so let's put them on the screen. So these are the common variants out there. Do you want to talk about them a little bit quickly? I know it's very technical, but just maybe just touch on briefly.
Absolutely, yeah. So as I said, the variants have multiple mutations. We are calling double mutant, triple mutant. They have much more mutations than that. What mutations we are also interested in are the mutations which are affecting the spike protein, because that is the protein which makes the virus enter into the cell before it start replicating. So these are called variants of concern. By WHO has classified as a variant of interest, concern, and of fatality. Variants of high consequence. There is no variant of high consequence as of now. Mostly variants we see are the variant of interest, which are normally variants which are passing into our community is the variant of interest. What we are worried about is the variant of concern, when there is evidence of increased transmissibility, more severe disease, that is increased hospitalization and death, as we are seeing in India right now. We saw UK, we saw Brazil. Significant reduction in the neutralization by the antibody generated during the infection, vaccination, or the treatment like monoclonal antibody. Then we call them as a variant of concern. These are the variants which actually will lead to, massive tsunami of the second phase of the vaccine of the infection. So the original virus these are named with the Pango lineage or next strain method. We don't want to go into that. The SARS-CoV-2 original virus was from Wuhan. As we know, it is technically named as D614G. The British variant we saw had named as B117. I will go by the technical name rather than the country name. I don't want to use the country name as a first initial for those strains. So they saw these three mutations in the spike protein. These are either substitution of one amino acid to other, or there was a deletion. What they have done, particularly this mutation N501Y or 618H, they affect the spike protein receptor binding domain and increases the entry of the virus into the cell. When the virus enters very quickly, it replicates very quickly and spreads very quickly. So it increases the infectiousness of the particular virus, and those are the mutations responsible for that. Now, the other mutation is that deletion of HV6970 that results in the evasion of your immune system. Your vaccine sites from the spike protein are actually missing, and then the vaccine does not work properly. And your antibodies from the previous infection doesn't work. That means you will have the reinfection. You are sick with the virus and you are in the hospital, you're getting convalescent plasma. That's not going to work because of the mutations. So it basically results in the increased infectiousness, so more spread. For a example, in California, we saw the mutation 501Y and 493LR, and that was 20% more infectious than the original virus. Although there was a question about it was more severe people, more severe infection or not, but we saw that in Brazil, we are seeing that in India, that there is a more people getting sicker, although the data still has to come from India yet.
Right. So, the variants are important, but I think still, there was a new study yesterday that Pfizer vaccine, mRNA vaccine, is pretty effective against the Indian strain, the 1.617, B1.617. So, so there is no need to panic. You got to still use the vaccine. You got to still use your common sense. Use the social distancing, use the masking if there is a high caseload in your community. And we'll see, these viruses, in my opinion, become, as the vaccination goes up, will be community to community different. So in other words, if a community have high vaccination rate, they will have less caseload in those communities, and the communities where they have a less vaccination rate, they will be endemic there. So it's like, for example, measles. It never goes away. More you have kids vaccinated, more the kids um, don't get it. But in certain community, for cultural reasons, religious reasons, they don't want to take it, personal reasons. And those communities, the measles never go away. I think COVID will have the same fate. Uh, what you think?
COVID is going to stay with us, Ranjan. I hate to say that, but that's the fact. Question is, will it be causing that much severity of illness, or will it be a mild cough and common cold like disease? I don't see that happening in next 1 or 1.5 year, at least, until everybody is vaccinated and we stop this virus from replicating and mutating. But it will be around, it will be there for a long time, and vaccination is only way we will be able to prevent it. We may not be able to eliminate it like influenza. Influenza, we get vaccinated every year. We're still around the country, communities, and but people get very mild sickness. They are back to the work in 2 days.
Let's
So
talk about influenza for a minute. I know, I've been seeing zero cases of influenza, and I was looking at data on influenza, and it's interestingly less transmissible than the COVID-19, the influenza. So with the measures we've taken in big cities, in congested area, in the hospital setting, in different nursing homes, of washing hands and using the mask, the influenza has disappeared. So there is wisdom, in my opinion. So let me give you a interesting data. In 2019, there was 20,000 plus deaths from influenza in the United States, and in 2020, with the COVID-19 precautions, there were less than 1,000 deaths. So that's pretty stark in terms of, if we use standard precautions like we use, for example, any bacteria, we use what we call universal precautions. You wash your hands, you go in the room, you come out of the room, you wash your hands, don't touch your eyes, don't touch your face, use a mask if it's a inhaled bacteria or virus. I think the countries which got burnt with SARS in 2000, the Eastern countries, like Japan, like China, like Hong Kong, Taiwan, South Korea, they've been using masks when there is winters or there is high risk of transmission of the respiratory virus very effectively. In my opinion, I think the masking should stay with us for flu season, and that will prevent a host of mortality, even if corona become less, and in addition to the vaccination for influenza.
well, believe it or not, masking works. You are right that we. I have not seen a single case of influenza which need to be hospitalized or in the hospital at all. I have seen start seeing some cases recently, but of the para-influenza or RSV, as Florida is, the mask mandate is gone. So we will see those cases more once people start mingling more and stop using the mask, universal hygiene methods, hand washing always works. Washing hand is an important part of your hand hygiene, is important part of your any activity you do in the hospital. Masking definitely works. So hand hygiene, masking, social distancing, and vaccination. These are the four things you should be, focusing on to prevent these uh, any kind of infection, not just the COVID, any kind of respiratory illness. You will see pneumonia will go down. The bacterial pneumonia. You will see all these viral infections will go down. Um, and in hospitals, initially with the all those PPE kits, we saw C. diff infection going down very quickly. There were very less C. diff infections. So personal hygiene and personal protective equipment, they both are important and they both work for sure. And that's the key.
Right. So the take-home message is, unless you have, Guillain-Barré with vaccination in the past, take the vaccine. Unless you have serious side effects from vaccination in the past, because COVID is unpredictable even in younger folks. Point number one.
Absolutely. Anaphylaxis to any component or Guillain-Barré, as you said, these are the only two major contraindications,
Right.
which
So if you have
you should.
allergies to different things, that's not a contraindication. Take your EpiPen with you, but the
Enough,
risks and benefits.
yeah, unless you have anaphylaxis, yeah.
Right. So that's number one. Number two, what you put on the slide, keep doing the social distancing till, everyone in your household has been vaccinated, and, keep in that bubble. Now, if someone new comes in, you got to be careful because they may be asymptomatic carriers, so you got to use your own common sense there. And then hand washing is always useful. And if you're in a hospital setting, nursing home setting, PPEs are fantastic in preventing barriers for any infection, not just COVID. Let's just get some more comments here. I know people have been patiently waiting. Sandy Lander said, "Hi, Dr. Mahajan. It's Stephanie, and great information. Thank you, Stephanie." Mark had a question. Mark is saying, how much protection does a person have if they have previously gotten coronavirus? That's an evolving science, Mark. What we know so far is what Dr. Kalra and I said the same thing, is that you're going to get some protection, but whether that protection going to last, how long it's going to last, we are looking at the data on that, but we are not sure. Some patients get a little bit sick and they are asymptomatic. Some patients, their antibody titers are not as robust. Common sense tells us it's going to be not as durable, that kind of immunity. And then if you go down the granular level and look at whether the antibodies, IgG, IgM, which we check, are they neutralizing? We don't know. So answer to your question is, yes, there is some protection, but it's not as Dr. Kalra pointed out, as robust or consistent that we can bank on it. So you got to take the vaccine in addition, because of that give you consistent neutralizing antibodies, and the whole community have similar kind of protection, and that gives a little bit less room for mutation to happen, and you have less breeding ground for the viruses. Anything
One,
else you want to add?
one more point I want to add, as you might have heard from some people, and I have heard from some people, after getting the vaccination, people getting their antibody level tested, and they say, "Hey, I don't have antibody." So when you get a coronavirus infection, you get a polyclonal antibody. You get antibody to nucleocapsid, you got antibody to envelope protein, you got antibody to spike protein. The test which the labs are using is the antibodies to nucleocapsid, and we are giving the vaccination to the spike protein. So if you really want to get tested after the vaccination, you should get the test for the antibodies to the spike protein, which is not very much commonly offered. I think only few labs are offering that. So don't get worried if somebody say, hey, I got vaccinated and I got my antibody tested, and they are just giving water to me. So that's not a right answer. I think the test is wrong, and we are looking the wrong antibody after the spike protein vaccination. So I think consult with your doctor before you get tested for the antibodies.
And I'm not a big proponent, Lalit, of doing that test anyway, antibody test, because it does not give you any knowledge other than, for example, there was one exception. There was a lady I saw who had pulmonary fibrosis, and the it was honeycombing on the CAT scan. And I asked her, she said she had the RT-PCR test done, like 3-4 months ago, and it was negative. I said, RT-PCR could be negative because depends on what phase of the disease you're checking the RT-PCR. If you don't have enough material, then you won't be able to pick up RT-PCR through your nasopharyngeal swab. So long behold, I did the antibody test. That's one of the rare exception. I did the antibody, and she had antibodies positive. So I think in those cases now as you said, we're seeing higher caseload of interstitial fibrosis in patients, and if they had a negative RT-PCR, does not rule out COVID, and the antibody test will be useful in those patients. Otherwise, it has no value. Convalescent plasma, it's not panning out, or some of the patients want high titer convalescent plasma being available, but if the convalescent plasma doesn't work, why bother checking the antibodies?
Yeah, convalescent plasma we are not using anymore. We have not seen any benefit. In fact, it can be of some problems to the particular person, because when you are using convalescent plasma, you are exposing the person to the multiple antigens from the different host, and in future there may be a problem. So we are right now not using convalescent plasma. Means we have available, but I am particularly not advising it.
Right. All right, so we're coming to the end of the show. I know we went through a long talk, and it's been a very emotional talk for both of us, with our families and friends struggling right now in India. And we want to pray and hope and pray again that they all come through unscathed, and and they do okay, because everything goes up, comes down. So the cases will, and they're already plateauing out in big cities, but it's not gone yet. So we just need to keep them in our prayers and hope that they will do well. Anything else you want to add to what we discussed, Lalit?
No, I think we covered pretty much everything. Definitely go out and get vaccinated, and don't be in rush to unmask yourself. I know the Florida has no mask mandate at this time, but I will be still very cautious. I think we have to learn the lessons from the other countries, that this can happen here. It has
Absolutely.
happened before in New York, when you saw lines outside the hospitals. Same thing is happening in other countries right now, and we don't want that to happen again. Let the hospital system not get overwhelmed. You should be cautious, wash your hand, social distancing as much as possible, and masking, and get vaccinated. I think these are the four key points that you can prevent this from happening.
Thank you so much, Lalit. That was so informative, and we appreciate your time. I know you're busy and you have to make hospitals around day and night with all the other infectious critters other than COVID out there. So, appreciate your time, and may your family and friends are safe in India. And God bless you for spending the time with our, patients and our listeners here. Thank you.
Thank you for having me. Appreciate it.
Yeah. Take care.
Thank you. Bye.
All right, so this brings us to the end of the webcast today. We went overboard, so we're going to not do the breathing exercise today. I know you guys look forward to, but you should be doing yourself at home. I taught you a lot of techniques, so it's very important that you keep doing that at home. With that, I want you to have commitment to tell your friends and family to go get vaccinated, and don't let your guard down till we get higher herd immunity with the vaccination of the population in Florida. Wear the mask, as Dr. Kalra said, and we'll come through this, with our American fighting spirit one more time. With that, namaste and God bless.